and our past CGP chairman Dr. Raghavel sir and Dr. Ravi Shankar, Dr. Yashoda, they are all the past secretaries of the IMA CGP. And welcome our today's speaker, Dr. Karthikeyan, and all the other members. Now, I request our national president to give his address first. Over to you, sir.
Good afternoon, friends. Dr. Prasad is not there? You are the chairman?
He'll join after some time, sir.
Okay. Dr. Amruta, Dr. Karthikeyan, Dr. Yashoda, Dr. Ravi Shankar, rest of the members who have joined this. Dr. Amruta has been doing a wonderful job in CGP when she's been organizing regular CMEs, and this CME once again, today's CMEs once again is an important subject what they have chosen. CGP, I don't know how many branches are functional in the country right now, but we should, I think, if the CGP hasn't been started in branches throughout the country, you should see that they start at the branch level also, and they should also conduct regular programs.
Yes, sir.
Of course, when I went last time, you said you have taken up two projects in that. One was about echocardiography, or what was that?
Another one is the family medicine, sir.
Family medicine. So family medicine, of course, is a very important subject you are taking.
Yes,
so hopefully this webinar will give us insights of rehabilitation after. Is a very important subject, and I'm sure the learned Dr. Karthikeyan will give us the insight of this. So I convey my greetings and best wishes. Thank you.
Thank you so much, sir. I am proud to introduce today's speaker, Dr.R.Karthikeyan, Professor and Head Department of Physical Medicine and Rehabilitation, SRM Medical College Hospital and Research Center, Kattankulathur, and is the Clinical Director and Team Physician, Special Olympics for us. Completed his MBBS from Tanjavur Medical College and MD Physical Medicine and Rehabilitation from Rajamutiya Medical College. He is an expert member in Technical Resource Group for Emergency Rooms, that is, Subcommittee for Road Traffic Injuries, constituted by Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. He is an expert member in Committee for Course and Training Development for First Respondents, Tamil Nadu Effect Skill Development Center for Healthcare, Government of Tamil Nadu and India. Participated as lead designation in medical and team physicians for our Special Olympics team at World Summer Games 2023 at Berlin, Germany, and World Winter Games 2025 at Turin, Italy. It's a special invitee to participate in the Independence Day parade on 15th August 2025. We are very glad to invite you, sir. Over to you, sir. Over to Dr. Karthikeyan.
Thank you, madam, for your kind introduction. So it's always a prestigious moment to deliver anything for my IMA, the mother of all the medical professionals. Thank you so much for this nice opportunity for all the senior members. And with the permission, I would like to share the screen.
Yes, sir.
Okay. Is my screen visible, ma'am?
Visible.
Thank you so much. Yes, ma'am. Thank you so much. So, first of all, I should extend my heartfelt thanks for giving me an opportunity to introduce a topic which is not given much importance in the day-to-day healthcare system. That's called the rehabilitation phase of healthcare. So it's my privilege to present my little knowledge and experience in this area of rehabilitation medicine. So the rehabilitation is the term coined by WHO as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interactions with their environment. So mostly, I would say the term rehabilitation is being used synonymously for de-addiction. So whenever people come to me as rehabilitation department, they say they mean as the de-addiction, but rehabilitation is the set of health intervention which is applicable to any disease involving any organ, which I want to emphasize. So as we all know, these are the phases of healthcare. Previously, it was categorized as promotion, prevention, treatment, and recovery. And after recovery is the rehabilitation. A person will develop a disease. When a person develops a disease, we need to prevent it. And if at all he develops, we need to cure. And next would be the rehabilitation. That is to make the person come back to his near normal. So this is the these are the different phases of healthcare. But now it is redefined as the concept of rehabilitation is starting from the prevention, starting from the level of prevention till the definitive treatment, and after the definitive treatment till the follow-up in the community. So the concept of rehabilitation starts from prevention till the reintegration of the society. So this is the current concept. So I would like to emphasize on these important findings or the statements from the WHO. That is, rehabilitation is an essential part of universal health coverage along with promotion of good health, prevention of disease, treatment, and palliative care. So rehabilitation is a part and parcel of the entire healthcare delivery system. And it says that an estimated 2.4 billion people are currently living with a health condition that may benefit from rehabilitation. So still we are not able to cope up with the needs, the rehabilitation needs of the people who are getting treated. So it says that more than 50% of people do not receive the rehabilitation services they require. This is what the current status is. Now the people live longer. Then previously we were concentrating on the longevity of a person. So now we have accomplished to a certain extent where our lifespan has increased. But now we have to focus on the quality of life, which is the focus of the rehabilitation medicine. So I would like to again say that the elderly care is very important, as we are going to have the proportion of elderly people is going to increase during the coming years. So as we can see the graphs, we can see that between 50 to 54 till 75 to 79, the proportion is going to increase. So the need for rehabilitation comes when the number of years we are going to live, that is, the longevity has increased, thereby the people are going to live longer, where the geriatric proportion is going to increase. So in that case, we have to now focus on the quality of life for the extended phase of their life. So that is the main motto of rehabilitation. And not only the geriatric, then again rehabilitation is one specialty which takes care of the impairments and disabilities. The UNICEF says 240 million children with disabilities around the world are being undertreated or not taken care of properly. So it shows that the importance of rehabilitation and the rehabilitation professionals, what is the challenge in front of them in terms of the early phase of life, that is children, as well as the later phase of life, that is the geriatrics. So this is the home page, that 1 in 10 children worldwide live with disabilities. So now it shows what is the responsibility of us to focus on the rehabilitation so that these children will have a better quality of life. So rehabilitation is healthcare is treating or managing the adverse impact of the disease, improving one's potential for a better quality of life. On the other way, prevention and management of impairment and disabilities which comes out of a disease. Though we treat the disease and cure the disease would have left certain impairments and disabilities in a person so that the person is not able to live a normal life. So, if at all we want to accomplish the complete benefit of the treatment what we have given, we should rehabilitate them properly so that they are living a better quality of life. So, I would like to use this analogy that the tsunami came in 2004. It was few hours. It went off. But the impact of tsunami was lasting for more than many months, for which we have struggled a lot to rehabilitate the people. It is the same way the disease comes and goes without treatment, but the disease will leave back certain impairments and disabilities. Unless we manage these impairments properly, we are not going to get the complete benefit of the treatment what we have given. I would like to quote the transition of the mortality from 2009 to 2019, a decadal change. That is, in 2009, the number 2 and 3 of the mortality is the diarrheal diseases and the neonatal diseases. That is, I would say it is the communicable disease. But over a period of 10 years, a decade, now we have come across the transition of the communicable disease to the non-communicable disease, otherwise metabolic diseases or lifestyle diseases. So this is the one transition. Second is, we have advanced in terms of diagnostics, therapeutics, surgical skill sets, so that the mortality is very drastically reduced. So now the people are made to live long with all the successful advancements of our healthcare. Again, this slide shows that this is the pie chart showing the disability adjusted life years. Previously, when we say in 1990, the tally was 60.9 with communicable diseases. But after, by 2016, we can see that slowly we have got transition from communicable to non-communicable diseases, so that with the advancements in vaccination and the antibiotic prophylaxis. So this is the healthcare transition. The epidemiology of various diseases got transitioned over a period of time. So with all this understanding, we should know the importance of rehabilitation as such. So when I say rehabilitation, this is the difficult questions we come across in our day-to-day practice, that my son or a daughter met with an accident, had a spine fracture. Though it got operated, I am not able to move my legs and no control over urine and motion. What to be done next? Met with an accident, but the vertebral fracture got fixed, but the person is having a spinal cord injury, is not able to move and not able to control his urine motion. What next? Surgery is successful, but what next for me? At the age of 45, now the young strokes are increasing. So at the age of 45, I got a stroke. My right hand and legs are not working. Leg is not working with slurring of speech. Can I come back to normal? So this is what we come across. This question, tough question, we come across most commonly in the hyperacute or acute stroke units. We would thrombolize, we would have done craniectomy, the patient is saved, but the residual impairment and disabilities makes a person to ask this difficult question. Of course, in various domains, I would say, after my heart procedure and surgery, whether I can do my works normally or I went for a stenting, I went for a CABG, whether I am able to do the works normally or my child is with a developmental delay. Is there anything can be done? I have got operated for my hip, knee or spine. When can I get back to normal? My son is an elite sports person who got injured his ankle or shoulder. Can he get back to his sports performance? And last but not least, I lost my leg in an accident, want to have an artificial limb and walk again. Can I do that? So these are the various questions we come across after we say our treatment is over, our surgery is over. The last but the most difficult question. These are the questions we face, and these are the questions which are worth to get answered. Now, with all this background, we have got the healthcare transition from longevity of life, that is adding life to years, to the quality of life, that is adding life to years. So this is the transition we have come across, and this one slide shows the importance of the concept of rehabilitation. And also, rehabilitation is not specific to gender, as we have the obstetrics and gynecology or andrology. This is not specific to gender, not specific to age like pediatrics or geriatrics. And this rehabilitation is not specific to organ like hepatology, cardiology, neurology, or any such distinctions. The rehabilitation medicine is one specialty which is function specific. Let us mention any disease. If that disease is going to cause an impairment, which is going to make an adverse impact on rest of their life, to revive them back and get back to their near normal or the best possible potential, that is rehabilitation medicine. So what are the subspecialties of PMR or physical medicine and rehabilitation or rehabilitation medicine? So as I told, any organ which is going to have a disease got treated, then we need to rehabilitate it. There comes the subdomains like neurorehabilitation, cardiac, pulmonary, pediatric, geriatric, sports medicine and rehabilitation. Of course, now it has gone as a separate specialty. Interventional pain management, musculoskeletal medicine, cancer rehabilitation, post-surgical, podiatry, diabetic foot care and rehabilitation. So these are the established subspecialties of rehabilitation medicine, which is being functioning in various hospitals, both government and private. So I would like to quote a few clinical examples to emphasize the importance of rehabilitation. Let us take up the neurorehabilitation, where we treat the persons with, most commonly the persons with spinal cord injury and stroke. So this is one 27 years old male who has sustained a spinal cord injury, a vertebral fracture and a spinal cord injury some 14 years back from a remote village of Tiruvannamalai. After that, he got operated in a government institution. After that, after the surgery, he went back to his home, never went to any hospital after that. He was bedridden, no access to any rehabilitation. So he was there for 14 years. Right? So after 14 years, a lot of complications. I got a call from an NGO. We brought him to our hospital, and actually we wanted to see his bladder, whether there is any stone or not. So we took a pelvis X-ray. To our surprise, we saw that there is an overriding of a greater trochanter with complete loss of head of femur. And then when we did an ultrasound, one side a kidney was completely contracted. Then when we did a renal artery Doppler study, it was a renal artery thrombosis, where the post-traumatic renal artery thrombosis is not so likely to occur, but unfortunately this fellow has got it. So 14 years, nowhere he went for any hospital after the surgery, got his avascular necrosis of femur with all deformities of pelvis, bladder contracted with contracted kidney, so with renal artery thrombosis. This we have explored after 14 years. And he had a very bad pressure injury, where when we put a finger into it, it was just going to the periarticular surface. So we treated him for 3 weeks with all necessary antibiotics, all supportive management. So at last he came out of the infection, septicemia, got cleared of his wound to a certain extent, though we cannot completely cure it. We actually advised for a flap, but the patient didn't accept it. So unfortunately, after 14 years, we have explored this. This is because he has never had any orientation or awareness regarding rehabilitation, what to be done, what are the exercises, how to keep himself fit so that he can lead a better quality of life after the surgery. So this is one example which I want to emphasize, the lack of rehabilitation and the complications he succumbed to. And this is one another fellow who had a very bad perineal pressure injury. So pressure injury in the perineal area is not so common again. This we have brought him from a remote place, again in Tiruvannamalai district. And this person had a fracture of his tibia, proximal tibia, because he had never done any exercises. He was just lying on bed. So all his joints got stiff with heterotropic ossification. When a physiotherapist went and moved his limb, because of osteoporosis and the stiff joint with heterotropic ossification, the proximal end of tibia has gone for comminuted fracture. So these are the complications which we come across when a person is not properly taken care of after the definitive treatment, and after a long time when they are getting a lot of complications, it becomes very difficult to manage. So this is one another patient who was in Foley's catheter for a very long time, not properly managed. Completely he got the tear of his glands where the Foley's catheter got exposed. So this is the tip of the iceberg, where when there is no concept of rehabilitation, so all these people succumb to these complications, which very badly affect their quality of life, and literally they are suffering. So after a vertebral fracture gets fixed, though we say that the spine is fixed and the surgery is success, he will ask the questions, very difficult questions, which I have again not able to move his limbs and it is bent or deformed, unable to take his food on his own, bladder bowel habits are not normal, whether this condition will improve or not. If so, the difficult question asked by the attender is, how long will it take, and is it worth spending time and efforts after this? Actually, this question which I face in the routine clinical wards, how I would say is, I cannot say that how long is going to take, but there are two options. There are two ways of going for rehab. One is to improve his potential, which I will not know how far is going to recover. But second important is prevention of complications. So if we are putting him on rehab, at least we can prevent the complications so that he will not have a new set of problems along with the spinal cord injury. So what are the problems in spinal cord injury? If at all we are not managing it properly, so what are the problems? We get pressure injury, spasticity, thromboembolic disorders, orthostatic hypotension, cardiac deconditioning, autonomic dysreflexia, pneumonia, bone loss, fractures, muscle loss with wasting, heterotropic ossification, neurogenic bladder bowel, paralytic ileus, thermoregulation disorders. So this spectrum of problems after the spinal cord injury, after the spine gets fixed and the patient is made to go home, we never have an orientation that the patient is going to have this big spectrum of problems for rest of his life if not managed properly. So once we are discharging after a spine fixation, so we should know that this fellow is vulnerable for these sort of problems, and if at all we want to accomplish the complete benefit of the surgery, we need to prevent this and manage this properly, which is good for the patient and his rest of his life. So I would like to cover the stroke also. Like nowadays, as we see that the young strokes are exponentially increasing because of the abnormal lifestyle, and then increased prevalence of systemic hypertension, dyslipidemia, and then class 1 lifestyle. So this is the data from the World Stroke Organization, that is 90% of all strokes are linked to 10 modifiable risk factors, and 1 in 4 people over age 25 will experience stroke in their lifetime if not managed properly, and 101 million people are living with a stroke aftermath. So this is the very alarming figure which we get from the Stroke Association, that we can very evidently see that the number of strokes, especially the young strokes, are exponentially increasing, which is going to really have a very bad adverse impact on the patients as well as their family, their young age. Come on, again, along with the spinal cord injury, in stroke, what are all the problems? There will be altered level of consciousness like coma, vegetative state, minimally conscious state, confusion, lethargy, obtundation, stupor. So these are all the various levels of consciousness, altered level of consciousness. A person will have tracheostomy, which is again we need to manage properly. We need to have a decannulation protocol, manage the secretions, make them to swallow, proceed with functional, fiber optic endoscopic evaluation of swallowing, make them to swallow, breathe properly, and we have to decannulate the tracheostomy, pressure injury prevention, Rice tube or peg feeding, and then bladder and bowel management. This is going to be again, even after the definitive management of stroke, either thrombectomy or craniectomy, then even after that, the patients are vulnerable for this many problems. Again, motor, we have categorized to different domains. That is, in stroke, we have motor, that is paralysis or weakness, spasticity, poor balance or coordination. In sensory, there is problems in hearing, vision, taste, smell and touch. Cognitive, that is shortened attention span and loss of time sense, increased awareness of self and others. Communication and language disorders, aphasia, alexia, and regulatory disturbances in sleep patterns, eating habits, bladder and bowel disturbances. So, and if not managed properly, again, the stroke can lead to spasticity, shoulder pain, capsulitis, rotator cuff injury, complex regional pain syndrome, brachial plexopathy, pressure ulcers, and osteoporosis. Again, falls, DVT, bladder and bowel dysfunction. So what the current practice is, immediately after the definitive management of stroke, we say that இனிமே வீட்ல போய் பார்த்துக்கோங்க, physiotherapy பண்ணுங்க, அப்படியே கொஞ்ச நாள் பார்க்கலாம். This is the standard statement we tell them before discharge, and the patients, they do not know what the problem is. Actually, with due respect to physiotherapists, I would like to say that physiotherapists, yes, they are the apt people for taking care of the motor part of the stroke. So as I have highlighted, the stroke has different domains of impairment, starting from cognitive, communication, regulatory disturbances. So I would say, in my experience, most of the time, the cognitive, communication and the bladder problems are not being managed properly. And then they come with a lot of complications regarding this. So a physiotherapist, though they do a good job for motor part alone, this spectrum of problems in stroke requires a teamwork of an occupational therapist, clinical psychologist, speech therapist, which is headed or coordinated by a medical professional, mostly the rehab physician. So always I would say stroke rehab is a teamwork. It is multi-domain related. So just we cannot say veetla poi physiotherapy mattum pannunga. We are not going to give or do justice for the person. So again, one important question is, people or the patient caregivers will ask, sir, idu vande brain cells la vande, if the brain cells dies, people say that it is not going to recover. Is it worth going for rehabilitation? The concept of rehabilitation thrives on two important properties of the neurons, that is redundancy and plasticity. The brain is an excellent organ which has lot of tolerance, which has lot of capacity to adjust itself, which is named with these two terms, redundancy and plasticity. What is redundancy? Within a neural network, a dropout of a limited number of single cells or cell-to-cell connections can be tolerated without much dysfunction. This is how most of the lacunar infarcts, which happens over a period of time, by virtue of age, they goes unnoticed because of this excellent capacity of neurons, that is redundancy. So cortical reorganization, neurogenesis, axonal sprouting, dendritic plasticity, angiogenesis, all these happens within the brain by itself, so that I would say that it manages itself to a certain extent. That is why the lacunar infarct goes on. What is neuroplasticity? It is still more intense variety of, or the higher version of redundancy is the compensation of territorial lesions affecting entire or large parts of neuronal networks come from parallel networks that provide the same function but are underused in the healthy brain. So it means that whatever the dormant neuron that is there present in our brain, that will come into force, that will come into compensation, so that to a certain extent the brain will manage its function. In fact, there are studies which shows interhemispheric compensation also can happen, which plays a major role in neuroplasticity. So that is again reprogramming of neuronal circuits. Stimulus of plasticity can occur through use of damaged circuits by active training. So when I say neuroplasticity, the stimulus of plasticity occur by repeated active training. The golden period of neuroplasticity is the first 6 months after the brain injury. So whatever I say, redundancy, neuroplasticity, sprouting of axons or neuronal reintegration, all these things can happen mostly within the first 6 months after the brain injury, what we call it as the golden period after the brain injury. So this requires an active structured training. That is what we always emphasize. Within first 6 months, please try your best. So there are adequate literature evidence that adaptive neuroplasticity can really make wonders, make the brain to recover to a certain extent, so that the person can have a better quality of life than with the injury. So what are the salient principles of neuroplasticity? When I say that brain is going to recover, so it means that there are certain principles. That is, let me not go in detail. That is, time matters. That is the one of the point is time matters. That is as early as possible. Salience matters. That is the activity, the functional training what we are giving. So mostly in corporate hospitals, they train with an activity with which the person is not exposed. For example, that person would have never had his food with fork or spoon, but they will be training as it is mentioned in Western textbooks. So we should know what is the salience, what is salient for that person. So we should train that person with the activities as early as possible, with adequate repetition, with adequate intensity, so that the brain gets stimulated, so that it can take up its function. So this neuroplasticity is very, very important. So this is what recently we have introduced virtual reality for our patients, so that they actually it shows a very promising results. Just a minute, I'm not able to click it. Okay, this is the virtual reality for cognitive training for our patients. It shows a very promising results, and we are planning for an extensive study with more number of study subjects. Okay.
Any problem, sir?
Struck it. I don't know why got struck. Just a minute, madam. Date, okay. Okay. So this is, our patient is undergoing VR-based cognitive training. So patients are very happy. They have better compliance. Okay, this is the electrical stimulation, where the patient is given the stimulation for the floor of mouth, muscles along the floor of mouth, to improve their deglutition as a preparatory work for decannulation of tracheostomy. So neuroplasticity, this I would like to quote as an interesting finding. This gentleman has never opened his eyes, and when we asked him to reply, he never replied. So he was just his GCS it was E3. He never opened, only with the intense pain he was. But to our surprise, we came to know that this gentleman used to talk on the phone most of the time, as he is a politician. So then, just casually I tried that cell phone kudunga. I just give him a cell phone. To my surprise, this gentleman started talking without even opening the eyes. He started talking. So now actually this is one evidence how cell phone has really made an impact over the the conditioning of our brain. This is a very surprising finding which came across. Never opened his eyes, but he is talking over the phone. And also careful observation in rehabilitation is very important. So I train my team for careful observation so that they should not commit this sort of illogical interpretation. So what do you mean by post-op patients are statistically normal? Well, some are in hypotensive shock and some are in the hypertensive crisis, but the average blood pressure of them all is normal. So this should not be there because rehabilitation is of very small, minute changes which we have to have a watchful eye, record it properly every day, which is very important. So interventions in neurorehabilitation, what actually we do? As people say that go to a physiotherapist and they will manage, that is not the same. There are many interventions we do, that is for consciousness and cognition. We do coma stimulation or multimodal sensory stimulation, cognitive retraining or manual or machine based, use of cognitive enhancers, certain pharmaceutical agents like citicoline, modafinil, trazodone, pyracetam. It is not pyroxicam, I'm sorry. It is motor. For the motor part, we do positioning and splinting because as the days goes on, from the flaccid, the person will develop spasticity. So we should not allow the person to go for deformities. So positioning is very important. Splinting, passive range of movement, stretching, strengthening, balance and coordination, muscle relaxants. So this, both the physical as well as the pharmacological has to go hand in hand, and swallowing and language communication training and neuromuscular electrical stimulation for pharyngeal muscles, deglutition training, which is the prerequisite for tracheostomy decannulation, bladder bowel retraining. So all this happens as a rehabilitation after a stroke so that the person recovers in a peaceful way. And apart from that, in between they will develop pressure injury, if at all, even though we take utmost care, they develop electrolyte imbalance, most commonly hyponatremia with SAID, or else they will develop pressure injury, infection, septicemia. So all these again in between, when as and when these sort of untoward complications happen, we need to manage on time so that we focus on improving their potential for rest of the rehabilitation. So rehabilitation team as such is a physiatrist, otherwise called as a rehab physician, and it has a set of the medical professionals like neurologists, neurosurgeons, rehabilitation nurse, physical therapists, occupational therapists, speech language pathologists. Of course, we have all these people in our team, which they are doing a wonderful job. We have a social worker, dietitian, an orthotist for making prosthetics and orthotics. So this is the comprehensive rehabilitation team where they have to contribute to their maximum with all commitment so that the person comes out with good outcomes. So all these I was emphasizing with the neuro rehabilitation. One another important is cardiopulmonary rehabilitation. So most commonly we come across this question that, sir, I had a heart problem, I had a MI, so I went for stenting, CABG. So whether I can come back to normal or not, if so, how to come back? So what are all the things I should do, I should not do, how I should get normal by structured training. So this is what is called as the cardiopulmonary rehabilitation. Heart problem was there, stenting was done, CABG was done. Next day he is not going to straight away get out of a couch or bed, he is not going to walk. So we need to retrain the heart and lungs, which requires a structured rehabilitation program. So it is a medically supervised program for the prevention of heart and lung dysfunction and to revive its function if one has experienced the cardiopulmonary disease or a procedure. So there are three phases. First is the inpatient phase, the second is outpatient phase, and third is the home-based rehabilitation phase. So all these phases have, again, they have micro modules. We need certain parameters to properly evaluate and make sure that they are not getting into any complications, and slowly they are improving with their functional potential. So what are the common interventions we do, like breathing exercises, respiratory muscle training, graded ambulation, graded resistance training, progressive walking training. So we have certain parameters like resting heart rate, target heart rate, and then permissible maximum heart rate, and then rate of perceived exertion. These are all the various parameters we use, so that based on the protocol is customized based on the patient's resting condition of the heart and what is his capacity or the endurance. So no cardiopulmonary rehab protocol is standardized. Though we have a protocol or a template, it has to be customized pertaining to a person in terms, especially in terms of their age, the resting cardiac function, and all other comorbids. So these are all the various interventions like breathing exercises, respiratory muscle training, pairing techniques, graded ambulation, and then resistance training, and then gait training. So all these step by step, we do it carefully, assessing the various parameters. So I would like to introduce three important terms, like what is called as METs. It is one MET is defined as the amount of oxygen consumed at rest, which is equivalent to 3.5 ml of oxygen per kilogram of body per minute. So this is MET. See, we always quantify the activities in terms of METs. For example, a person who is sitting on the chair, it is 1 MET. He is going to sit or about to sit to stand or walk, it is 3 METs. So we won't say as the activity as such. We see every activity in terms of METs, so that it will tell us what is the capacity of the person. So cardiac rehabilitation programs utilize MET levels to assess a patient's functional capacity. And what is the resting heart rate? We have a table, and the maximum target heart rate would be roughly, we say 220 minus age is the maximum permissible heart rate. And what is the rate of perceived exertion chart starting from 1 to 10? We start with the activities starting from light and easy, then comfortable pace, comfortable with some effort. So slowly we have the protocol of increasing the activities from minimal METs with minimal RPE, and slowly we have to progress based on the patient's endurance and their capacity. Another important area is the pediatric rehab. Mostly we deal with children with cerebral palsy, then autistic spectrum disorder and pervasive developmental disorders. So one important finding which I would like to highlight is there are two important domains in pediatric rehab. That is, one is the cognitive or higher mental function, and second is the motor part. Mostly one will be missed when the other is focused. Either they will miss the motor part, the child will have uncontrolled spasticity, deformity, which is going to limit their ambulation, or else they will leave their cognitive training, so that the child will be having a mental retardation, or the mental growth is not being addressed properly. So the ideal pediatric rehab is we have to carefully structure the protocol in such a way that both their mental cognitive function as well as their motor function are being parallelly taken care of with due importance. So that is very, very important. So these are all the various foot deformities which comes in cerebral palsy because of muscle imbalance. Either we treat them with the muscle relaxants, oral muscle relaxants, we give baclofen, or else intramuscular Botox injections. If not, there are centers where in rehab medicine they do rehab corrective surgery. Though I'm not trained for the corrective surgeries, there are centers, especially the All India Institute of PMR in Mumbai, they are very good in these corrective surgeries of pediatric rehab. These are the various lower limb deformities in cerebral palsy. When it is not being addressed properly, these gives rise to the deformities. One important point I would like to highlight is the earliest phase of spasticity has to be managed properly with oral muscle relaxants or Botox. If not, the unaddressed or uncontrolled spasticity for a long time will cause deformity where there will be a stiffness of the joint with periarticular calcification or the ligament stiffness or capsule contraction. So only as long as the muscle is spastic, it is amenable for any medical management. When the spasticity is not being managed properly and we are leaving it to the stiffness of the joint or the capsular contraction or the periarticular calcification, the heterotropic ossification, we have to go for the surgical procedure, which is going to be really tough for the children. So managing spasticity at right time is very important. Again, the cancer rehabilitation, which is one area which is not being given due importance, but which is very, very important, is cancer as such causes a lot of problems irrespective of the organ involved. The cancer as such will cause a lot of adverse impact over the metabolism of the person, causing a protein energy malnutrition, cachexia, and then sensory motor disturbances. So irrespective of the organ. But again, if particular organ is involved, for example, head and neck cancers, they will have swallowing issues. CA prostate, they will have urinary issues. So pertaining to the organ involved or irrespective of the organ, the cancer is going to have a lot of adverse impact on one's metabolism and the function. So rehabilitation it has 4 phases. That is, to a certain extent, we have to prevent, palliative, restorative, and supportive. So a person, even though is having a cancer, is going for radiotherapy or chemotherapy, the cancer is being taken care of. That is fine. But in terms of his function, every day if he is going to have pain, every day is going to have stiffness of joint or sensory motor disturbance, it is not, we are not giving the complete solution for the person. So the rehabilitation, starting from his nutritional advice, is all his functional training like passive, active range of motion, or else improving his endurance by breathing exercises. So all this as a whole, we have to keep him functionally good, which is very, very important, which is the main objective of the cancer rehabilitation. And last but not least is the disabilities management. So rehabilitation medicine or rehabilitation is one concept which really manages the persons with disability. You cannot find any specialty, the OPD of any specialty flooded with persons with disabilities. But rehabilitation medicine or physical medicine rehabilitation is one specialty. It focuses on prevention of disabilities, and if at all disabilities already occurred, management of disabilities. So the disability management is also the domain of the purview of the rehabilitation medicine. So these are the, as per our RPWD Act, we have these many number of 21 types of disabilities. All these disabilities will have their own spectrum of problems which is being taken care of by rehabilitation. And to our surprise, we can say that out of our, as per census 2011, that is 2011, out of 121 crore population, we have 2.68 crore persons who are disabled, which is 2.21% of the population. So 2.68 crore people, for these people, the management of their disability and their health status is being taken care of by one specialty, that is rehabilitation medicine. So for these people, the concept of rehabilitation is very, very important. And managing this disability has 2 types, social model and medical model. Both of them are taken care of by the rehabilitation physician. So apart from their vaccination, nutrition, managing their medical problems, all these things, the rehab medicine is one specialty which focuses on even the social model like disability certification, provision of rehab aids and wheelchairs, advocacy for their rights, social participation, employment, and keep them fit to involve in recreation as well as sports. So rehabilitation of disability involves both these domains, that is medical as well as social. Other important areas of rehabilitation where we need to give proper importance is amputation prevention. First of all, the amputation should be prevented, especially because of diabetes or any other metabolic diseases, vascular diseases, with a risk factor of smoking. So amputation prevention is very important. And if at all amputation is done, post-amputation rehabilitation to keep their stump fit, to keep them fit with all the prostheses, maintain their endurance so that they can lead their normal life. Interventional pain management, geriatric rehabilitation, podiatry or foot care, or the other important areas of rehabilitation, which is very essential for our healthcare. So this is one slide. Is always when we are not equipped for our needs or our in any aspects of healthcare needs, the patients themselves or the disease themselves, the problem themselves find a way. Either we have to form a way or else the nature will find a way. So I was thinking that how innovative this gentleman is. He was not having a stand for his cell phone. So he just used his casting as a cell phone stand. So this sort of innovative need-based ideas are very much essential in healthcare, and especially in niche or very important specialties like rehabilitation. The take-home message is rehabilitation is an important phase in healthcare to make a person regain his quality of life, to achieve the complete benefit of the treatment. Rehabilitation again is a teamwork managed by a medical specialty as rehabilitation medicine, periodical follow-ups, timely referrals to rehabilitation within the golden period of rehabilitation is very important. So this one slide, which always show it at the end of any presentation, doing nothing at all versus small consistent effort. Let us start with small changes over a period of time. The consistency will give a good result. So thank you so much for all your valuable time and patient listening. I wholeheartedly thank the IMA, CGP, Amudha ma'am, Raghavelu sir, Ravishankar sir who has generously given me this opportunity, and also to giving an opportunity to highlight an unnoticed area like rehabilitation among this august audience. Thank you so much. I would like to welcome any questions or improvisations over my presentation. Thank you so much. Ma'am, can I stop sharing my presentation?
No?
Right.
Yes, sir.
Questions from audience?
Hello.
Hello?
Hello. Good evening, sir.
Good evening, ma'am. Good evening.
Surgery. After how many days we should start rehabilitation, sir? One of my patients, he has got a spinal D12 vertebral fracture and complete transection of spinal cord, sir.
Okay, it's Asia A. I would say that not after how many days. It has to start from day one. Once he has come out of the theater,
okay, sir.
Once the surgery is fixed, he is hemodynamically stable. The concept of rehabilitation starts like positioning his limb in the right way, and then we have to move his limbs, passive movements, if at all pneumatic tourniquet, pneumatic compression device for prevention of DVT. So all this, the concept of rehabilitation starts from day one. Not, we have to start, because one thing I should emphasize is we should always forecast the complication. Second hourly, if you are not positioning properly, we should know that he will get pressure injury. When his lower limbs are not passively moved, he is going to get DVT. So all these things we should have forecast, all in our mind. We should equip ourselves, all our team, everybody, most of the, because one shift nurses, if they are leaving without change in position, or if they are not taking care of their limbs, passive movements, then there is no excuse. By the time the patient may develop pressure injury or a DVT. So day one, we have to start the concept of rehabilitation.
Okay, sir. Thank you.
Thank you, ma'am. Thank you.
Good evening, sir. It has been a very nice presentation.
Thank you, ma'am.
I'm basically a pediatrician. I would like to know what is your protocol for rehabilitating autistic children, sir?
Ma'am, all the autistic children are not the same. There are certain children who will have, there are different, problems in autism, right? Certain children will have a monotony of their activities.
Yes.
Certain children have poor social interaction. Certain children will have their repetitive impulsive behavior. So we
Yes.
need to carefully evaluate the child, what actually the problem is. Even among the whole spectrum of ASD symptoms, which is dominant, and based on that, and also we need to counsel or interact with the parents. So the rehab protocol is based on the careful evaluation of the child, what are its symptoms, and second is what is the living environment of the child, and what is the what involvement or the status of the parents or caregivers. So based on that, we need to tailor make the protocol. But I would say that any symptom which is really bothering, there is no specific template as such. If the mom says that the child is very impulsive, he strikes, that is the first thing that has to be tamed. So in that case, the careful evaluation gives us the scope for making a protocol.
Thank you.
If you can give the brief history of the child, I can tell you what exactly to be done.
Yes. There is a 4-year-old child. He has come from UK. Both parents are working. The child had been born during COVID. He was about 6 months when the COVID struck. So he had been allowed to fend for himself. There was a nanny appointed by the parents. But the nanny is English speaking. The child is used to only local Tamil language. They have recently moved to UK. So that child has got a temper tantrum, frequent meltdowns, very impulsive in his behavior. But at the same time, his growth and nutrition and growth are quite normal. He is quite comfortable with his sibling. But with everybody else, he is very stubborn, really violent with others. With the mother, he is a little okay, but he doesn't like being cuddled by anybody except the sibling. The sibling is almost like a mother to him. They are 6 years apart. But then he has not spoken a single word so far, sir. He is now 5 years. There is no eye contact. But now we have been giving him therapy. As he said, we have been addressing all his issues for the past 2 months. But now he is making eye contact, but it is a fleeting, not a sustained eye contact.
Thank you, ma'am. Thank you so much. So I can assess that the child has more of the communication issues, socializing issues, right? So as you said, the parents are working and they are not spending quality time with the child.
Yes.
And it is being taken care of by the caregiver, paid caregiver. So all this shows that the child has not given an opportunity to communicate properly.
Yes.
So first thing is, even in my experience, I was seeing a child who was told as deaf mute. This actually அவங்க வரும்போது என்னன்னா காது கேட்காத மாதிரி இருக்கு குழந்தை, பேசவே இல்லை. So first thing I told is, ask the mother and father either take a long leave or resign their job, stay with the child. So first thing is, for the child to reciprocate or communicate, it has to have a stimulus. So we should give the child the adequate stimulus with all socialization. Then only the child will interpret how to react for that situation, for that oral stimulus, then accordingly. So for this child, the problem would be the deprivation of socialization and communication. So in that case, the advice for the parents or the caregivers is, spend more time with the child. Take the child out. Ask them to communicate more. Then only the child brain will get matured for its communication, and then it will interpret how to react for it. So unless we give a stimulus, we cannot expect the child brain to react. So ideally, the first and foremost thing is, the parents has to be counseled.
Thank you, sir. Thank you.
ma'am. Thank you.
Karthikeyan,
Sir, சொல்லுங்க sir.
could you tell something about speech therapy that you tried to give for an aphasic post-stroke person? You always talk a lot about that. We always leave the patient try to talk at home and what is it? What are the modalities or ways you try to put the patient back on speech therapy? What's the one which you do in the speech therapy? Maybe not your core group, but still I think you can enlighten us.
Yes, sir. So actually, the problem with is aphasia or a communication disorder is either it may be a receptive aphasia or an expressive aphasia. That is, a person has to receive the stimulus, he has to integrate, interpret in the brain, and then he has to express it. If the person is not able to receive or he is not able to understand what you are telling, then it becomes a receptive aphasia. And though he is able to interpret what you are asking, but he is not able to express. What is your name? It becomes a receptive aphasia. But he can understand that you are asking his name, but he is not able to communicate. Or else, that is called as expressive aphasia. அதுலயுமே வந்து என்னன்னா பேரு சுத்தமா சொல்லாம இருக்கிறது, தப்பா சொல்றது, மாத்தி சொல்றது. We have lot of different types of aphasia, sir. So that is one thing. So aphasia is broadly we classify as expressive and receptive and expressive aphasia. Suppose if the person is having everything is okay, only there is a motor aphasia, it is a easy form of aphasia to treat. That once we give him a oromotor stimulation exercises in terms of manual exercises or certain muscles to be stimulated, what we call it as neuromuscular electrical stimulation, and giving him some exercises with various sounds, syllables, so that we can improve the motor aphasia. That is one thing. The toughest part would be the complete global aphasia. That is, in that case, we have to start with non-verbal communication. That we should know whether the brain is receiving the stimulus or not. In that case, before the non-verbal, before verbal, we go for non-verbal. That we will give him a chart of various colors or various objects, familiar objects, and ask him to identify whether he is able to perceive the stimulus or not. So it is called as non-verbal communication. So to start with, we will go for non-verbal communication, and then monosyllables, bisyllables. It is all about the patient's ability and the extent of the brain injury, sir. So easy to treat is motor aphasia, global aphasia or sensory aphasia. We start with non-verbal communication or stimulation, and slowly based on the patient's status or his progress, we will improve it, sir. It requires a structured program, sir.
Sir, Raghavel, sir.
Hello.
Solunga, sir.
Dr. Karthikeyan,
Yes, sir.
in the case of paraplegia, what is the role of massage and native medicine?
Sir, I do not, actually massage don't have any value, sir. Actually, massage or native medicine, in fact, I have come across many people who are landed up with complication. Even last week we lost one patient. He is 30 years old male. He was with us with D11 paraplegia. We managed him very nicely. So we have put him on Foley's catheter. We asked him to go home, asked him to review after 2 weeks. But unfortunately, the family members, they are not convinced with me, my version, that it will take longer time or he may not be able to walk, where we need to equip him for alternate ways.
No, why I am asking this question?
Yes, sir.
I have personally seen this happen. This is a person who is related to the bodyguard of M.G. Ramachandran. He was a neighbor.
Okay, sir.
So he was brought from Mysore paraplegic, totally.
Yes, sir.
And in those days, we have Indian Medicine Hospital in Kilpauk. So there they showed him and they gave some oil, red color oil. And because being my neighbor, I used to see the massaging with that oil. They brought him totally paraplegic. After 6 months or 7 months, I saw him walking back to Central Station and back to Mysore. This is, personally I saw it.
Okay.
That's what I asked. See, massaging as oil is only for lubrication, but massaging is my understanding is that the finger, that sensation is being passed on back to the central nervous system, and the communication is re-established over a period of time. This is what maybe the basic. I have personally seen this happening. One is massaging, the other one is Indian medicine oil.
Yes, sir. Actually, it may be an incomplete injury. We have ACI A to E, sir. It depends on the level of injury. So I don't have any positive experience of giving complete relief with the massage and oil. Maybe for the patient satisfaction, topical I will allow, but not orally. I won't.
Not orally, it's only topical. Everything topical. And two ones is to come daily and do the massaging for whole below the body, below the abdomen.
Yes, sir.
I have witnessed it. That's what I'm
happy that he has recovered. So I'm happy that he has recovered, but I don't have any scientific evidence for that.
குற்றாலத்துல தான் சார் அப்படி பைல்வான்ஸ்ல வந்து ரெண்டு போதா போவாங்க. டாக்டர் யசோதா சார்.
Good evening, Dr. Karthik. With the permission of CGP Secretary, I'd like to. This is the left-handed children. They start with the left hand. How to change it to right hand? Any tips? What is the rehabilitation for that?
There is no need to change it, ma'am.
Like
there is no need.
Normally, some children, they eat by the left hand, write by left hand. Then we say the brain is working on the right side. Both sides is working. So we have to change. The mother will be shouting at the child, saying right on the right la saapudu, right la pannu, right la. But the child will be still doing on left hand. Left-handers are there. Can we, with rehabilitation, change totally into right hand?
There is
Why
no need
should
to
we
change
do it?
ma'am.
There was a question asked by a pediatrician there in the crowd.
Yes, the pediatrician is also Yashoda only.
There is no need to change, ma'am. Handedness is the prerogative of the child. There is no need to change it.
But what happens, these children sometimes, the mother, why she is upset? I see in general practice, I am a general practitioner, they say she goes to the toilet, uses this, she eats
ask the mother to go to a psychiatrist first.
Yeah.
No, can we change
I have one question. Can I ask, Amuta?
Yes, sir. Yes, ma'am.
Yeah. How a child of 2 years is unable to speak, how long should we wait?
How long? I think pediatrician, ma'am.
Child should be able to vocalize by 9 months to 1 year, ma'am. There is no need to wait. Either there is a problem, there is absolutely no, as sir said, there is no communication at home. Maybe the stimulus to speak is not there. All his needs are met. He is not allowed to speak, perhaps. Or he doesn't have a sibling at home to stimulate him. Or a peer group activity. Put him in a play school and try, ma'am. Otherwise, let us identify any other problem, coexisting problem, ma'am. Okay. Thank you.
Thank you.
You think this is Shobha, ma'am?
Yeah, I'm Shobha. I joined late.
She's from Mumbai. She's the 2026 Dean of IMCGP.
Oh, very good. Nice, ma'am. Nice.
Hello, nice to meet you.
Nice, ma'am.
Any other questions?
Sir, is there any role of music in rehabilitation, sir?
Very well, ma'am. There are actually they have given there are a lot of descriptive studies on various ragas in rehabilitation, especially with brain injuries. They have given descriptive study evidences that it has decreased the resting heart rate. It has in terms of autonomic dysreflexia, it has helped. There are a lot of descriptive studies, but level 1, I mean, further evidences are need to be made. So that is what I say. But I won't say. I will say there are beneficial effects. Can't say no. But still, we need to document it in a very structured way.
Okay, sir.
I think it was a nice talk, but what I also wanted was, how is physiotherapy going to help in a chronic bronchitis, bronchiectasis, rheumatoid arthritis patients, osteoarthritis knee, low back pain? I think on the next time you try to innovate these talks into it, the cold orthopedics.
Okay,
That is where a family practitioner, since we had a pediatrician, it was nice that she could really utilize your talk to enhance our knowledge also. But then for a family physician's point of view, we often see a low back pain repeatedly, patients coming at what point of time, what's the management, what is it to be given, the exercise. Today, we have cervical spondylosis, very, very common because of the IT industry, people sitting at home and doing with the bad ergonomics of armchairs. They have a bad ergonomics, so they have a back pain and a shoulder pain, a muscle spasm in the neck, osteoarthritis knee, back pain, cervical pain. All these things, I think you are going to innovate in your talk the next time.
Sure, sir.
The cold orthopedics is what is this? So the whole problem of the family practitioners. And your bronchiectasis, that's why I said rehabilitation in medical cases.
Oh, medical cases, okay.
No, yours was a very in-depth talk.
Actually, sir, why I framed my presentation in this way is, there are a lot of people, after the management of a stroke or spinal cord injury, they are not giving proper advice and properly referred to a right person. So I thought,
as you said, we just say, go have physiotherapy, but don't guide them. Guide them or tell them how effective or how useful it is.
Yes, but the problem is little more wide, where we need still more intense, coordinated efforts.
Your talk will be put up in the CGP website soon.
Thank you, sir. Thank you, sir.
Thank you, Dr. Karthikeyan, for your wonderful presentation. Because
most
people don't know about this rehabilitation and all. I think many of our doctors also, they don't know much about this, though only they are not joining this thing. In our Tamra branch, because of some untoward incident happened yesterday, maybe a reason for that.
Yes, ma'am.
For joining this.
Right,
it's a very wonderful presentation, sir.
Thank you.
We can have your presentation in some other day also, sir.
Yes, ma'am. Yes. Okay. Thank you so much.
Okay, thank you so much.
Thank you,
for all the delegates who
Thank you,
joined.
everybody. Yeah.
Thank you, all the participants. Thank you.